Okay, I'd like to welcome you all. I'm Matthew Bolton, Senior Associate Dean for Global Public Health, and this is the first in our Global Crossroads lecture series offered by the Office of Global Public Health. We're offering this lecture series this year, both in person and remotely via Zoom, and I think we'll probably retain that model throughout the course of the year and see how it works out for us. My understanding is that we have quite a number of participants over Zoom today. I do want to mention before I introduce our speaker about some upcoming events from the Office of Global Public Health. We'll be sponsoring a virtual global health and development career panel on October 11th from 5 to 8 p.m. With the locale to be determined. We're co-sponsoring that with the School of Nursing, and we'll be hearing from a group of panelists who are U of M alum, current faculty, and others from public health and nursing. We're also sponsoring this year, co-sponsoring a global health film series in partnership with Michigan Nursing, Medicine, the Center for Global Health Equity, and the Taubman Library. The first global health film series, or the first event in this series, is going to be on October 27th from 6 to 8 p.m. And the film is entitled The Life and Legacy of Dr. Paul Farmer, in conversation with U of M colleagues who knew him well. And again, we'll be hearing from three panelists who worked directly with Dr. Farmer during his career. Please keep an eye out for announcements about future talks in the Global Crossroads series. We'll have more throughout the course of the year. Before I have our speaker join us up front here, I want to let you know that we have about 15 minutes set aside at the end of the talk for Q&A, and I'm sure our speaker would be glad to entertain that. So without further ado, I'd like to introduce Dr. Suzanne Gilbert. She's well known in international public health and eye care sectors as a researcher, grant maker, program planner, trainer, and policy maker. Her base of operations for over 40 years is the Seva Foundation, of which she is the co-founder. Today, she is Seva's Senior Director for Research and Strategic Opportunities. She earned her PhD and Master's in Public Health degrees from the University of Michigan, where she studied upon completing her Fulbright Fellowship in Nepal. Her first Seva project was the design, implementation, and analysis of the 1981 Nepal Blindness Survey, the first nationwide systematic study of blindness. She's built many long-term collaborations, including Seva's Global Site initiative, which today engages over 100 partner eye hospitals and NGOs in 20 countries worldwide. Her major focus now is strengthening data literacy and research skills among Seva staff and partners as a tool to improve service delivery and to use scarce human resources and funding resources as well. I'll let you read about Dr. Gilbert's many global health committee memberships and chairpersonships in her bibliography, which is available online, but among several others include serving as a participant on expert panels of the World Health Organization and as a member of global committees of the American Academy of Ophthalmology, Global Education and Research. Dr. Gilbert.
Thank you so much. I'm delighted to be here. Coming back to University of Michigan and especially the School of Public Health, is truly homecoming for me. I'm delighted to have a few minutes to address a topic close to my heart, and that is research capacity building, which I see as a hugely important tool for public health, often overlooked. I'm going to go into just a few points today, a bit of background about Seva Foundation and Michigan origins. Then, because not all of us are involved in eye health in an ongoing manner, I'll give a few basics about global eye health issues, and then address why research capacity building, give a few case examples, and share some of the priorities for the work I'm doing moving forward. Of course, then we'll have discussion at the end. In terms of Ann Arbor connections, I'm starting in the upper left-hand corner here with Lane Hall. which at that time was Center for Asian Studies. And my first years at University of Michigan campus, starting in 1970, were actually at Lane Hall, studying anthropology and linguistics, focusing on Asia. Then I was fortunate to be here at the School of Public Health, it's front and center, and where, as we heard, I received my master's in public health in 1975 and was in the first cohort of doctoral students in health behavior and health education, completing my PhD in 1983. So it's been just a few years that I've had a contact here with the university campus in Ann Arbor. My last appointment in Ann Arbor was at the Towsley Center for Continuing Medical Education, which is part of the medical school's Department of Postgraduate Medicine. And it's there that I was a staff member when the Seva Foundation was established in 1978. So Seva Foundation is now celebrating its 40 plus year anniversary. This is a photo from our second meeting. I'm pleased to be able to point out a number of Michigan members here. Dr. Carol West, who is an ophthalmologist and was at the School of Public Health. Dr. Larry Brilliant, who is here as a faculty member. His wife, now Dr. Girija Brilliant, who was with me in that first cohort of students for the health behavior, health education doctoral program. The impetus to start the Seva Foundation came very much out of the spirit of the completed smallpox eradication program. Here is Larry Brilliant with the youngster Rahima Banu, who was the last person detected to have smallpox. And Larry literally wrote the book on the management of smallpox eradication while here at University of Michigan. We have, as part of Seva's roots, a very colorful past. We have among our founders and early organizers, and actually still in many cases, members of the Grateful Dead, a lot of members from the kind of Woodstock era music world. And we actually got started and we had our founding meeting in Michigan in 1978, thanks to a check sent by Steve Jobs to Larry and Girija Brilliant after he read an article they'd written about smallpox eradication. He was very moved, sent them a check and said, please use this money well. And that was after their paths had crossed actually in India earlier on. But this was the beginning of Seva and was just, as I say, over 40 years ago, and things have kept very lively ever since. So Seva's focus remains to end avoidable blindness. We're a nonprofit organization. Our focus is to work with local communities around the world to develop self-sustaining programs that preserve and restore sight. As we heard, this work takes place through more than 100 partnerships in institutions in more than 20 countries, including the United States, where our big focus is with Native communities. Seva's methodology we refer to as the Global Sight Initiative. It's our way of partnering with institutions that are more mature and become mentor institutions of more fledgling eye hospitals and eye programs around the world. So we very much work on a partner building program that then helps to equip those partners to reach out and help other institutions in their area. The work is very patient-centered. We're focusing on equity of care as well as quality and operational research on how to improve our work is a big aspect of our overall methodology. And I'm pointing out here an early article about Global Sight Initiative that was a Harvard case by Regina Herzlinger. In order to better understand what it is we're referring to when we talk about global eye health, I'm sharing a very important document that was released in 2019. This was the World Report on Vision, which was the first WHO-wide publication on global eye health. And it was the first time WHO put its imprimatur on this work beyond having it be a recommendation of a small unit within WHO. But the key thing for us to know is everyone, if they live long enough, will experience at least one eye condition in their lifetime. And the nature of those conditions is that of 2.2 billion people today who live with some eye condition, more than 1 billion of them have not been had their issue addressed. And this is our challenge. This is why we need research. We need additional ways of working so that using scarce global resources, we can double the number of people being reached in a timely manner so as to address some issues that are as simple as refractive error, people who need glasses. Whoops. Also cataract requiring surgery. 65 million people today need cataract surgery. Then other conditions, glaucoma, corneal opacity, diabetic retinopathy, trachoma, and also the need for reading glasses, which is extremely important as people age. One thing you'll notice is that some of these conditions require just a few minutes of service and the person is assisted. Others are life conditions that are going to need a lot of repeated care. And for that, we need to have really strong systems to be able to keep up. Also, let's face it, the majority of people with eye impairment are over the age of 50 years, as is those of us in public health know from those population pyramids. This is the fastest growing age group in the world, the over 50s. And so the need for this care is going to increase exponentially. I think I'm going back. So the challenges are many. I've touched on several of them. What I want to point out here is that there's a very close tie of global eye health with several of the sustainable development goals. And as a sector, the eye health sector is working to position ourselves relative to these goals because the eye is a tiny organ of the body, but it has tremendous implications for many aspects of life and the economy. And so we're putting a big emphasis on the relationship of global eye health with the Sustainable Development Goals. And there's some very good papers written on this. In fact, the eye sector is one of the few that's gone to the effort of documenting the direct relationship of eye health and the SDGs. Very importantly, as shown toward the bottom of this slide, 90% of those affected by vision loss live in low and middle income countries. 55% are women and girls who are always underrepresented in service delivery unless special efforts are made. And children with vision loss, particularly in low and middle income countries, are 2 to 5 times less likely to be in school. And we know that that makes a lifelong change for anyone. So Seva's capacity building didn't start with research. Our capacity building approach started first and foremost with service delivery. How do you organize yourself, organize your human resources, and organize systems for effective service delivery? Then we worked with many institutions in that regard. Seva capacity building then also grew to include training. How do we make sure that all institutions we work with have the ability to train and provide continuing education for their own staff? In some cases, our partners literally have departments of ophthalmology that have residency programs or fellowships in ophthalmology. In other cases, that training would include training allied ophthalmic personnel who are so vital on the eye care team, or managers, outreach coordinators, also people who handle. All these people need training, and we work to capacitate our partners and learn from partners and have partners learn from each other as to how to scale the training they offer in their institutions. And then finally, we get to research. And research is a strong through line throughout Seva's activity, but we've only recently made it a pronounced focus in our capacity building activities. As one of the first key activities of Seva Foundation was to respond to a request from the government of Nepal to establish a national program for eye care. And in order to ground that work, the first thing we needed was to know what is the extent of blindness in Nepal, what's it caused by, and where are the people? And so that then launched the Nepal Blindness Survey. I'm pointing out here in the upper left-hand corner is Larry Brilliant using a very early version of VisiCalc on the 10th Apple II that Steve Jobs produced. And we had it in Kathmandu till a few years ago, and then gave it to Steve's wife. The person above is Dr. Nicole Grasset, who was responsible for the Smallpox Eradication program in South and Southeast Asia. And following that very successful work, became part of Seva as a founder, and then for years pitched up in Nepal and worked on the Nepal blindness program, starting with the survey. And then here's an example of a Nepal blindness survey team, quite a motley crew. The survey resulted in a number of key publications that were important at the time, because as we heard, this was the first systematic study of blindness nationwide in any country in the United States. We still have yet to have any such data like this for the United States. And I'm pleased to note that 6 of the authors on the paper were from the University of Michigan. The just earth-shattering in this field. The conventional wisdom at the time was that most blindness was caused by trachoma, and there was a very distinct under-recognition of the importance of cataract as contributing to blindness, because blind people are home alone and they're not being seen on the street. And what we actually found was that of the blindness in Nepal, 84% was caused by cataract. And all of a sudden, we had on our hands the need to address eye surgery at a public health level in a country that had barely electricity, roads, and certainly not communication systems. There were many unintended positive effects of conducting the Nepal Blindness Survey, in addition to the vast benefit of the use of the data. One thing is the survey teams went on to become key eye health workers in the country. The process, the way the survey visits were made to villages, promoted eye care awareness for the first time, because at that time in Nepal, there were only 8 ophthalmologists. So almost no one had access to eye care. And this was very important for laying the groundwork. Also, the survey produced a plan for action that was immediately endorsed by the government of Nepal and World Health Organization. And then over time, in a short time, international NGOs were recruited to support development in different parts of the country. Now, long-term, we're very fortunate that people involved in the survey went on to become some of the leading ophthalmologists, ophthalmic assistants, and managers in Nepal. Some of them are still working today, 40 plus years later. Also, having the survey gave us a very strong baseline for comparison over time, which has been very useful in promoting this work and how to effectively transfer it to other countries. And then over time, operations research has been designed and conducted by Nepali colleagues who now train others in research techniques. So this really got the ball rolling on having an evidence-informed decision-making for this program, literally from month 1. So this work and others that we've then took on for a period of literally several decades led to our more recent impetus to really scale research capacity within those program partners who would be interested. And first and foremost was to embed research planning into program planning. and making sure that there were mechanisms in place for sharing those skills and applying them to us. And this really comes from partners, is to recognize that locally conducted operations research strengthens eye care. And I think you could fill in the blank with locally conducted operations research strengthens any kind of care because of the following attributes. It encourages partners to ask their own questions. These are not research questions coming out of a US or European university. These are research questions coming from the people who are doing the work. This kind of work improves information collection and analysis. It gives data more respect in the institution. It builds an evidence base on key interventions, helps us translate those findings into service improvement. And it's also important that doing this kind of research, being recognized as being effective at this kind of work, creates confidence and competence in a local eye health team and supports evidence-informed practice, which overall is a big goal of our work. A study, a review conducted by my colleague Ken Bassett and myself in 2019 of 3 different programs in over a 20-year arc, what they'd accomplished in building research skills indicated that when we talk about building research skills, we're really talking about 3 levels: the individual researcher, the creation of a research unit, and global collaboration across those units. And that's how Seva works in all of our capacity building, including the research. This is immediately pre-COVID, frankly. Seva's operations research projects were focusing on learning by doing through, this is a cross-section of 50 projects with 15 GSI partners. You'll see that the locally defined focus for the research was overwhelmingly, nearly half of the projects were services for children. And then looking at different aspects of the service delivery spectrum. But very importantly, these projects are defined by the people who want to improve their program, and we help to capacitate their effort to do so. Some examples of those projects include studying eye service utilization in the community, school screenings. Once a child may be given glasses, do they continue to wear them? What are the issues? Cost recovery efforts. Is it possible in sub-Saharan Africa to have a tiered pricing structure for services where everyone gets the same quality of care, but some people who have the ability to pay are asked to, which is part of the model in other parts of the world? Is that appropriate? Does it work? We find that yes, if it's done appropriately, yes. We've also done a lot more survey work to better understand the distribution and causes of blindness, as through that last bullet on rapid assessments of avoidable blindness. This study of what we're doing in blindness prevention and also looking at research capacity building led to establishing a specific program. And this is our kickoff workshop in Nepal. We brought together colleagues from 5 countries in order to focus on building operational research capacity for eye service improvement. And based on this, this meeting, we established the plans to work with these teams and a few others in order to strengthen this skill and practice. We took on this effort with the Indian Institute of Public Health in Hyderabad, India, and created together this operations research capacity building initiative. It was originally pre-COVID to have been 13 months, hybrid, getting together every quarter physically and in between people doing their work. As it worked out, it turned into a 24-month mixed methods workshop, learning by doing, focusing on 4 eye hospital teams. All of this, the capacity building Seva supports, involves teams. In this case, because this was relatively new, we needed to have the hospital medical director involved, so he or she would have an appreciation of what was entailed and what the benefits could be to the institution to do this work. We also needed a person who already was a research head, who was designated to be research head, take part. Data managers, and of course, practitioners were part of the team from a given hospital that would be involved in this 24-month workshop, which just concluded. And 4 of these eye hospitals were from, 3 of the 4 hospitals were from Nepal, 1 from India, and we had auditors from other parts of Nepal and Cambodia. So as we say with mixed methods, it was on the one hand, large group learning sessions via Zoom. And then each team had an assigned faculty member from Indian Institute of Public Health, Hyderabad, along with a Seva staff member. So they had additional coaching and more concentrated hands-on time, again, it was still virtual, in order to benefit from the large group sessions. We did a lot of cross-program sharing, where folks would be able to speak from each of the teams in terms of the challenges they were facing, the workarounds they developed, including all of us involved in research in a busy healthcare setting know a critical area to work around is how do you protect your time to do research in a busy clinical setting when you have hundreds of patients out the door. So there was a lot of sharing and creativity about how to do this and how to protect time and how to be able to really benefit from this workshop. And again, the assistance to this team was through all steps of the research process. And again, just a reminder, when I were talking about the research arc, we're being very comprehensive. We're starting with selection of the question or topic, again, done by the team with guidance from their facilitator guides. Developing the study protocol with all the facets that are involved in the study design and analysis plan and sampling plan and all those aspects of protocol development, which also included literature review and the entire spectrum. This then led to a lengthy period of implementing each research project. To do sufficient data collection and then begin analysis. Because again, during COVID, we weren't having the same numbers of patients or easy access to communities. In fact, for several of the months we were working, people might not even be permitted to leave their immediate zone or district and cross the line and go into another district search. The projects were very practical. An example would be one project was to examine 2 different methods of encouraging families to bring their children back for follow-up care after an initial eye examination where they were found to have a problem needing continuity of care. So we studied several different methods and to determine which ones work best under what circumstances. One of the topics was that a eye hospital partner recently had added a retina specialist who was able to address diabetic retinopathy in that community for the first time. And the community hospital a few kilometers away was seeing many people with diabetes, but there was a retina specialist a few kilometers away. So they developed a pre and post intervention study for encouraging the staff of the community hospital to refer people to the eye hospital so they could get the periodic checks required to identify early development of blindness from diabetic retinopathy and treat it immediately. All this work led to a lot of experience in coaching, in writing up reports, writing manuscripts, and publishing. Because we had some extra time on our hands, the teams published their protocols as a practice activity for then doing the final write-up and publication of their final manuscripts. But we're not done when the manuscript is done. We make it very clear. Our goal is to use the data, is to use this experience to improve service delivery. And we're just now getting into that stage as the final manuscripts are being approved by peer-reviewed journals. refer to this as COVID effect, and this will be a familiar sight. Again, all of our sessions, with the exception of a final one, had to be virtual. This is an example. You can tell I'm a cheerleader for research capacity building in health institutions. We happen to be applying this within iHealth. But what we have found are benefits and are, and some of these are aspirational or in place, depending on an institution. But first and foremost, our goal in doing this has been to kindle staff awareness of need for practical evidence, to just recognize there's a lot that we don't know. And how do we develop a systematic and user-friendly way of doing that within the institution? We have found that by doing this work, we kind of create more respect for those people who are doing the data management in a busy institution. We're popularizing routine data collection and its review, because collecting data is something many institutions do, but actually reviewing it and putting those results to action, it can be is found much less frequently. We've also noted that as groups do this work and gain recognition, they're able to produce global and local research collaboration opportunities where they can further strengthen their own skills, ask more questions, get more answers, put them to use. This then leads to publications and advocacy statements. But most important to us is when programs are able to use findings to improve service quality and sustainability within their own institution, and to promote that entire culture of continuous improvement. So forward, our focus is on working with groups who were engaged in that original operations research capacity building workshop to help them strengthen their research unit inside their institutions. All of those 4 institutions now have dedicated research coordinators or directors, a small team, a physical place, a few computers dedicated to this work. And there's a there for research that hadn't always been there before this work. We're also building research alliances across Seva staff partners and universities. Identifying funding for collaborative research, and also working to assess and improve research skill building among iHealth professionals more broadly, where we could work with these 4 institutions intensively. Life is short, we can't go that slowly for that long for all of our work, but we are constantly looking for ways to scale this work. And finally, and very importantly, is to apply research findings to improve eye care locally and globally, to develop cases around that, because there is some skepticism about investing this kind of time and effort into research capacity building. And so it's very important that we have these cases to demonstrate the value. We're in the process of doing follow-up interviews and ascertaining what difference this has made to the participants in the process. So those conclude my remarks, and I'm happy for us to have any kind of discussion that people would be interested in.
Can I ask you a question?
Yes.
I saw you were working in the Cox's Bazar camp, which I think is home to a lot of Rohingya refugees.
Approximately 1 million.
Yeah, I wonder if you could speak to in refugee populations in terms of the services that Seva is providing.
Yeah. Any fragile community requires its own particular skill set and series of approaches. Of course, it was important to us. We got involved in Cox's Bazar in part because we were working in Myanmar, and then we followed this community where they went into Cox's Bazar and realized that at that time UNHCR had no provision for anything regarding eye health. And in fact, we weren't really sure how high eye health would be on the priority list when people needed a roof above their heads, a way to handle sanitation, get clean water, et cetera. We were quite surprised the interest in eye health, in part. Used to wear glasses, didn't have them anymore by the time they got to Cox's Bazar after that sudden displacement. And so we started by doing, and you did catch correctly, we started by doing a rapid assessment of avoidable blindness, Cox's Bazar, not solely, of course, for the Rohingya community, but also for the host community. Anyone who was in the catchment area was included in that study. And we were surprised how much blinding cataract was in that population, given that so many of the people who suddenly come from Myanmar were coming with operable cataract that had not been addressed in Myanmar. So there are a lot of sensitivities and sensibilities, but what we did was we worked through local eye care institutions already in that area, help them develop the ability to expand their service delivery levels so they could also accommodate the many needs that were coming along with the people coming. And we also worked with a number of the eye care INGOs who already were working in that area to help them similarly scale up their services. We're very fortunate in that one of our coworkers is expert when it comes to working with refugee community and eye health. And so we were able to include his 25 years of experience working in more than 100 settings in the short term and long term to kind of build out what we would do in Cox's Bazar. Again, to express, part of Seva's orientation. Our goal wasn't to go in and treat a lot of people day one. Our goal was to create the baseline data that would be used to plan, carried out over time. So our big focus was on conducting that survey. We're just now on the verge of conducting a second one, which is focusing on refractive error of all age groups, from age 8 to 65 or so. And we'll get a better idea of eyeglass. But I guess an area that frankly I was surprised was the priority felt within the community to have eye health services. So high, but it is very high. So that's how basically, in a nutshell, we're doing it. But it's all being done through local service providers or helping to ramp up the ability of those local service providers to reach more people.
Gary Harper on a term, kind of shifting the term a little bit of capacity building. And I just wanted to get your take on it, but we've been adopting more capacity sharing. I just wanted to get your take on that kind of a term. Does it kind of resonate with the work that you're
absolutely.
doing,
Yes, in fact, I'm so glad term bidirectional. We regard all of this as being bidirectional. Everyone has a lot to learn wherever they are in the spectrum, and that's really the fundamental basis of the work. So, I mean, capacity sharing works great. I guess to use the term capacity building, I would see everyone is a capacity builder. It's not an expert. It's not the aegis of an expert in the sense of seasoned and trained. I mean, we all know, because we're in public health, experts are the people who are grappling with the issues day in and day out in their settings. And so I think establishing a different term to create the conversation is very useful. But that bidirectionality, at least bidirectional, is critical to what I would regard as true capacity building. For recognizing that.
lost what you've had along the way, it's debilitating to not have correction to your.
Yeah, thank you. Thank you. Yes, please.
Just a question. I came in a little late, so maybe the foundation ended up with the building skills along the research arc or the partners. Did the foundations
Well, I touch on elements, but I'll thank you for asking the question.
Can you just reiterate?
Yes,
the
I
question?
So thank you for asking how Seva got into the whole arena of capacity building and then also, or capacity sharing and including in research. And no, I'm very glad you asked. Seva, really one of our strongest springboards was the WHO Smallpox Eradication Program, an effort that would not have been feasible had there not been a tremendous amount of government support, a tremendous amount of human energy, and very good attentiveness to data. You will recall there was a big effort in smallpox, particularly at the end for containment and also tracking. And that meant that in the 70s, in very challenging circumstances, there had to be very good data systems. Some of the people who headed up that work were founders of Seva. Larry and Garrett are brilliant, Dr. Nicole Grasset, Dr. Steve Jones, and many colleagues from, in our case, particularly from India, Nepal, and Bangladesh, who were, we had a great respect for the importance of data as a tool, not as an end in and of itself, but as a tool. And that then led to our first activity that was to respond to a request from the government of Nepal to establish a national blindness prevention program, one of the first of its kind for any country, actually. And that led to our here from School of Public Health experts and the Institute for Social Research designed the survey that was done in 1980-81. And even today is still referred to as one of the most comprehensive surveys of its kind. And there's a very strong through line of then using those data over the years as build program plans and activities, and then to have as a reference point for how are we doing. So that's really been part of Seva's DNA. We really, by and large, started out as strong public healthers. And then because some of us were also ophthalmologists and in eye health, call for help from government of Nepal. That became a big focus of the organization and still is.
That's okay.
Do you have a
Do you have a
question?
question?
Okay, thank
Back
you.
there? Yeah, I wondered if you could say, you know, when I was in residency, talked much about internationally was trachoma, which would have been in the 1980s. What I saw your numbers in terms of the kind of relative positioning of the different causes of blindness. What's going on with the epidemiology globally of trachoma these days? And maybe you could repeat the question too. So.
Okay, yes. So so the question is, what's happening these days with trachoma? We noticed on an earlier slide, in the case of the Nepal Blindness Survey, it accounted for perhaps 3% of the observed blindness. And you know, what's going on? So in the intervening decades, since the 1980s, what you're referring to, there's been a big focus on eliminating trachoma as a public health issue. there'll always be reservoirs, there'll always be some degree of trachoma, but to really settle it out as a public health issue. And it's been very successful. There are now many countries that had been trachoma hyperendemic or endemic that are now virtually trachoma free. And there's a very systematic effort. A very important tool has been not only the study of community practices and improving community sanitation, a number of issues that are important in reducing trachoma transmission, but also the fact that at the time it was called Merck, Sharp, and Dome, gave a unlimited donation of azithromycin for use with people and communities with trachoma. There's been a lot of research about community use of the antibiotic relative to point-specific person use of the antibiotic. That the tool, having the antibiotic as part of the arsenal to use along with community awareness building, improved sanitation, importance of hand and face washing, all have contributed to a tremendous reduction in trachoma transmission. When you reduce the transmission and the recurrence of the condition, you are also preventing blindness from trachoma, because the blindness occurs with repeated infections. And of course, by reducing transmission, you're reducing the number of people who are contracting it. So we have a very good cycle now for trachoma. There's still a lot of work to do. There's still at least a dozen countries that are still have very active trachoma campaigns. But this was one of the prime targets the last 10 years of the Queen Elizabeth Diamond Jubilee Trust. She put a tremendous amount of resources into trachoma mapping, planning, training, and implementation through the Queen Elizabeth Diamond Jubilee Trust. It was very, very effective work, along with WHO, Ministries of Health, and many INGOs that had had this focus for many years, including, of course, coming out of the International Trachoma Initiative.
Was less there, but cataract, even for the Nepal study, and the majority of the eye issues among our younger population is. So what do you think is happening around that?
And then, so the question is, why are we finding so much cataract in these surveys? And a lot of it is because I think we're surveying the correct communities, the communities that have been traditionally underserved. And if a community doesn't have a cataract surgery program, they're going to have people with cataract. When we started this work, it was not unusual to find people in their 40s with operable cataract. Over time, as surgery is done earlier and earlier, we have to really, in many cases, those people have had their surgery. A very important contributor to the effectiveness of cataract surgery programs is that starting in the 80s, intraocular lenses started to be implanted in the place of the cataractus lens of the person, and they were restored to having very good vision after surgery without glasses. Again, another of the millions of findings from the Nepal Blindness Survey, where we looked into lots of issues, was we examined for a person who was being surveyed and examined, who had had cataract surgery. We asked, where are your glasses? Because if they weren't wearing their glasses, because they were functionally blind without their glasses after cataract surgery of that generation. Become more the norm, and Seva and partners really pushed this in the early mid-90s, pushed making sure that affordable, high quality intraocular lenses could be available to any program anywhere in the world, so that people, when they had their cataract, their lens removed, they could have a replacement lens inserted. And that's been very important. And Seva worked with the Aravind Eye Care System in India to produce one of the first global facilities, which today produces 10% of the intraocular lenses used in the world. So as we provided a very good quality result from cataract surgery, more people came to have their cataract surgery because they heard about the glass in the eye, the lens in the eye, and they saw how effective it was. It meant after cataract surgery, a person could go back to whatever work they were doing the day before they had their surgery or before they lost their vision. Whereas the earlier cataract surgery products up into the early 1980s, people would have perception of light, they'd have various blurry vision, but they could take care of children and perhaps farm animals, but couldn't do fine work and certainly couldn't read. So, so there's been a big cataract revolution. One more
I think
question?
so, yeah,
Okay.
one more.
Surveys that have been completed outside of the US have been really common. But not in the US. So
Good. So the question being, how do we get data inside the US? Well, there are some very important initiatives underway within CDC, which, as we know, has not been particularly well funded in recent times. The very important vision group in CDC that's set up to do statewide surveys. These are self-report surveys, so it's a little bit different than having an eye examination, but it's still very important data to collect. And we're hoping that funding for that work gets replenished. Also, of course, because of our insurance and Medicare, et cetera, we have a lot of data in this country. So we can learn a lot from who is getting care. So we can get a lot of information. There's some very important registries that offer access for anonymized analysis. But again, that's of people who are getting care. So as useful as it is, it doesn't cover everything. So I think it, particularly in a number of underserved communities, will be very important in the near future. Yes, so thanks again. I really appreciate being able to talk about eye health here at the School of Public Health, decades after we first started talking about the Nepal blindness survey with so many faculty and students. And so it's really great to see everyone today. Thank you.
Story.
I think so. Actually, I have my little notes. Guest speaker question.